After that, we're moving on to our ABC. These are the vital components, okay? Airway, breathing, circulation. I'm going to assess the airway of the patient using the jaw thrust maneuver. Okay, with jaw thrust. I'm going to assess breathing, look, listen, feel, looking for chest rise and fall, listening for breath sounds, feeling for breath. Okay? That's our assessment. To protect my airway, I'm going to insert an OPA, measuring from the tip of the ear to the corner of the mouth. I'm going to insert the OPA upside down, rotate 180 degrees, and put the flange rest against the lip. Okay? Airway, breathing, done. I'm going to initiate oxygen therapy. Depending on how my patient's breathing, if they're breathing adequately, between 12 and 20 times a minute, with adequate chest rise and fall, I'm going to use a non-rebreather, 100% supplemental oxygen at 15 liters per minute. If the patient's not breathing adequately, outside of 12 to 20 times a minute, or it's really shallow, or in some way inadequate, I'm going to direct another rescuer to begin ventilation with the bag valve mask. Again, 100% oxygen, 15 liters per minute. Okay, next you're going to handle breathing injury, because an injury to the lungs, to the chest area, is an immediate life threat. I'm going to expose the chest, okay, with the chest for injuries by inspecting, palpating, auscultating. Look, touch, listen. You can't look if you haven't exposed the area. Obviously you can't see it, right? So we expose the chest. We can also take the lungs with our stethoscope, listening for, breath sounds, presence or absence on both sides. Our major breathing injuries, the ones that you're going to see on the exam, will be either a flail chest, generally, or some sort of penetrating or puncture wound. Okay? Yeah, gunshot, stab, whatever. Something that's punctured the chest wall and gone into the lung. Okay, so for a flail chest or paradoxical movement, that's a section of 2 or more ribs, broken in 2 or more places, moving in the opposite direction of the rest of the rib cage. Treatment for that: bulky dressing, taped on both sides, stable ribs, and ventilation to the bag valve mask. Treatment for a puncture wound: occlusive dressing, taped on 3 sides. Okay, so I've assessed and managed any breathing injury. Moving on to circulation, I'm going to assess the pulse. I will assess radial and carotid at the same time, comparing and contrasting, checking to see if the radial is weaker than the carotid, anything like that. It's a test of perfusion. Okay? After that, we're assessing and controlling for any signs of major bleeding, because obviously if the person is bleeding out, their circulation is not adequate. So with my gloved hand, starting at the head, I'm going to scoop for major bleeds. Going down the patient, looking at my glove, each time I go, checking for signs of blood. You're going to go all the way down, both all 4 extremities, checking your gloves as you go for signs of blood. Okay? If you find any major bleeding, obviously you'll control that. Okay? Next, we're assessing the skin. A lot of people forget to assess the skin. Maybe because it seems like it's kind of thrown in there. But if you think about it, the color, temperature, condition of your skin is a sign of perfusion, which is part of circulation. If you're pale, cool, diaphoretic, obviously your circulation, your perfusion is not adequate. Okay, so we're checking the patient's skin. Most likely the examiner is going to tell you they're pale, cool, and diaphoretic. Trauma patient is probably going in shock. Okay? So at this point, we've gone through all of the major vital components, things that are going to potentially kill a patient within 5 minutes. So this is when you make your transport decision. Literally, if you say verbatim, this is a high priority patient, I want to transport as soon as possible and contact ALS. Those 3 points are both specific enough and vague enough to cover everything you need to say without giving too much information and possibly getting you into trouble. Okay? The examiners, they're good, but if you give too much information sometimes, it'll kind of give you the rope to hang yourself. So you want to give enough information without giving too much. So, high priority patient, transport as soon as possible, contact ALS. Okay?
At this point in the exam, the examiner takes 10 minutes, it's the 10-minute mark.
Yep.
You have 10 minutes to get to this. I think Tori did it in 2.
Plenty
I
of
mean,
time.
of course, you guys might be at that 10-minute mark, we'll get you down to that like 2, 3, 5-minute mark. So.
Right, so next, rapid trauma assessment. If it helps you think about it as we're doing our steps in order of priority. Mental status, ABT, transport decision, call ALS, those are our priorities. We've done those. So now, we're getting more information. The rapid trauma assessment helps us find out what's wrong with our patient, how we can treat them, and what we can tell ALS or the hospital when we get there. Okay? So starting at the head, we're checking for crepitus, broken bones, all moving against each other. Cerebral spinal fluid and blood from the ears, nose, mouth. Obviously signs of closed head injury. We're also checking our pupils, checking for pearls, equal round reactive to light. Okay? So we check the head. We're also checking DCAT BTLS, which you should all know. Forward diffusion, aspiration, penetration punctures, burden centers, laceration, swelling. Right? Say it once. You don't have to say it the whole thing. Just say DCAT BTLS from there. So we've done the head, unremarkable. Move down to the neck. Spinal step off. Tracheal deviation, jugular vein distension. Okay? Unremarkable, yes or no for any of these. At this point, you check the head, you check the neck, you can apply a cervical collar. It's not going to get away with assessment now. Okay? So I'm going to apply a cervical collar. Moving down to the chest and abdomen, we've already exposed. We've already checked the chest for signs of breathing injury. We can auscultate again to assess how do we have lung sounds on both sides, do we have equal rise and fall, things like that. Moving down to the abdomen. We're going to palpate the 4 quadrants, checking for rigidity, tenderness, guarding, anything like that, anything out of the ordinary. Does it elicit a painful response? Does it feel abnormal? Okay? Obviously signs of internal bleeding, air in the stomach, anything else. Moving down to the pelvis, the only thing we're checking for is stability. So you're going to push straight down and straight in. Does it elicit a painful response? Apparently it did. I'm sorry.
Tori likes to get carried away. She's a perfect fit for you guys.
There we go. Is it called stable? Does it elicit a painful response? Yes. Okay? Moving down to the extremities, going to expose. Make sure you verbalize expose, because remember, you can't inspect if you can't see. Expose the extremities. Palpating circumferentially, we're going all the way down to the extremity, checking for DCAT BTLS. If you want to get really detailed, shoot, check for the head.
But remember that you have to do each extremity. You can't just say one, say it. You have to go to each one and show them that you're doing each.
Demonstrate quickly with the chest, abdomen, pelvic, chest, go down the extremities, come down each arm. That's okay. Expose the arm. Never step over your patient. Always step around. Okay? Check the other leg. Check the other arm. Checking for DCAT BTLS all the way around. Okay? So we check the front. You're not done. This is 50% of the patient. Okay? There's a lot left. This is where you do what's called a log roll. You do a 3-minute log roll, a 5-minute log roll, whatever. As long as the patient gets turned properly.
And you guys will learn this upcoming week along with the spine board and what's on. So
I'll just give you a quick one, just a quick review of what it is. So you still have someone at the head. They've been there the whole time, holding C-spine. The person at the head is the one who directs the log roll. So they're the one who says 1, 2, 3, turn. So one person at the head, one person here, the other person here. These 2 people, their arms are crossed over. Okay? Ready?
come over your shoulder.
Sure. You're just going to have to roll it.
Yeah.
So we have 2 people here. So at the count of the person on the head, we're going to roll the patient.
1, 2, 3.
There we go. So we have the posterior. We're going to expose. And, you can auscultate for lung sounds on the back. I'm going to inspect the entire posterior to see that BTLS. Okay? At this time, I'm going to have another rescuer coming with a long spine board. That's 30-degree angle. Really detailed. Slide the board under the patient. Have the person on the head.
1, 2, 3.
Roll the patient onto the long spine board. Okay? I'll have additional rescuers secure the patient while I continue my assessment. I will maintain baseline vitals. The next trick that I was taught that might help me remember. baseline vital signs. Skin, pupils, respiration, blood pressure, pulse, capillary flow. 1, 2, 3, 4, 5, 6. Okay. I'm going to help you guys. Okay, baseline vitals, get a sample history if you can. So all you're going to say is, okay, I'm going to have additional rescuers care my patient. I'm going to obtain baseline vitals. I'm going to obtain a sample history if I can from any bystanders, anyone on scene. Yes or no, you can obtain it. The examiner will tell you. All right. So at this time, we'll transfer the patient to the ambulance. En route, we'll treat any secondary injuries. Time allowing, we'll do a detailed physical exam, continue our ongoing assessment every 5 minutes for an unstable patient, every 15 minutes for a stable patient.
You're done. So that's it. That's the steps in a nutshell. Of course, you know, today we just want you guys to get to know the steps. Later on, after today, we're going to throw scenarios in. We're going to throw in patient's condition. We're going to throw in, you're going to find a gunshot wound, and we're going to throw in the sample. We're going to throw in their blood pressure. We're going to get to that. I know some of you want that now, but right now, this is the foundation. We build on everything on this course, so you guys need to be awesome at this right here, the steps. And then after today, we'll throw in, you know, all the stuff that you need to go through a full assessment. So that's basically it, head to toe, the steps. 1 through, what it is nowadays?
25.
25.
I can do the whole thing, it's just no practice.
But again, Tori said, you know, we all have our little different ways, but we get to the same accomplishment, the same stuff. I might say stuff a little different than Tori. Eve might say a little stuff than us, but it's all the same, and we all get to the same point. We all have different styles. She has a different way to say what the take out vital sign. That's the first I heard it today. I actually liked it. So I might teach Quincy and use her example. We all take stuff from each other. So, but right now, continue. I mean, it's better to do this verbatim. My instructor, Tony, down at Montreal, you guys can do this at home, actually. The medical and trauma assessment, once we start giving you scenarios, you can take those scenarios and bring them at home. You can use it, you know, you can have a kid, and Andy's done this.